Well, hello everyone. Thank you so much for taking the time out of your day to join us tonight. Today, we're going to be talking about dysautonomia and what it's like to live with it. So for the month of October, we're celebrating Dysautonomia Awareness Month, so make noise for turquoise. And before we get into everything, we're just going to do a brief introduction on what our nonprofit is about. So Invisible Illness Awareness Network is a 501(c)(3) nonprofit organization, and we raise awareness for invisible illnesses, chronic illnesses, and disabilities. We also help students start affiliate organizations at their respective institutions so they can be leaders themselves and educate their peers on invisible conditions, especially those interested in pre-health careers, so we can create a more inclusive environment to benefit patients and their families who are affected by invisible illness. And today you're coming to our Invisibly Aware series. We hold 2 virtual meetings every month on different conditions and topics relating to invisible illnesses. And the first meeting of each month is a presentation on our selected topic for the month, which is dysautonomia this month. And the second meeting includes guest speakers talking about their experience living with, treating, or caring for someone who has the experiences or topics that we're going over for the month. So if you don't already, please follow us on Instagram, the invisible_illness_network. We post multiple times a week on different awareness days or different conditions and topics that we want to bring attention to. And our Invisibly Aware Series Instagram has all of our meeting dates, all of our guest speakers and times, and information about any events that we're doing. Invisibly_awareness_series is our ad for that. And if you scan the QR code on the slide, you can be brought to our link tree, which has a link to our website, our YouTube, where we'll be posting this recording afterwards, and our events calendar, newsletter sign up, and any other more interesting links and resources that we'd like to share with you. So a few disclaimers before we jump into today's meeting. None of what we're saying tonight is medical advice. So if you're concerned about any of these issues, please talk directly to your doctor. And please also note that no two people with the same condition have the same experience with it. So we have some guests who have the same condition, but they have different symptoms, different experiences in their life and when they were diagnosed. So just please note that no two people have the same exact experience, even if they do have the same condition. And we are not experts on these topics, but our guest speakers are experts on their own lived experiences and with their conditions. And we also are lucky enough to have a physician guest speaker tonight who will share his expertise and knowledge. So a little quick access check. I always forget to start off with this. We're going to do verbal image descriptions, each person tonight. So I'm Stephanie. I'm one of the co-founders and co-presidents of Invisible Illness Awareness Network. I'm a white woman with brown hair and I'm wearing a black dress. And if you need captions tonight, you can turn them on in the bottom panel of Zoom by clicking the CC button. If you have any other accommodation or accessibility needs, please message Sarah privately on Zoom and to let us know so we can make this presentation as accessible to you as possible. And regarding questions that you may have for tonight, please feel to put them in the chat at any time. You can also direct message Sarah if you want to ask your question anonymously, and we'll answer questions to the best of our knowledge, either throughout the presentation if it makes sense, or at the end. So let's do some brief takeaways from our presentation that we gave a few weeks ago now, actually, on dysautonomia and on POTS. So for dysautonomia, it's basically an umbrella term for a group of conditions that affect the autonomic nervous system, and it affects at least 70 million people worldwide, and that's on the lower end of the estimate. So the autonomic nervous system controls basically what happens in the body automatically, such as your blood pressure, heart rate, pupil dilation, digestion, your breathing, body temperature, sweat production, and more. So basically anything that happens automatically that you don't have to think about in order for your body to do. There's a lot of different types of dysautonomia, all with unique signs, symptoms, diagnostic criteria, and treatment options. And regarding POTS, which is the main form of dysautonomia we focused on in our presentation at the beginning of the month, POTS stands for Postural Orthostatic Tachycardia Syndrome, and it's a systemic life-altering condition. Diagnostic criteria includes, but is not limited to, an increase of heart rate of at least 30 beats per minute for people over the age of 19, and at least 40 beats per minute for people ages 12 to 19 from laying to standing. About 67% of people with long COVID are being diagnosed with some form of dysautonomia, with POTS being the most common of those dysautonomias. And the number of POTS patients is estimated to have doubled due to COVID. So without further ado, I'm going to hand it over to Prav Noor.
All right, thanks, Stephanie. So I'm Prob Noor. I'm a South Asian woman with black hair, and I'm wearing a black sweater. And thank you so much to our guest speakers here today. We really appreciate your time, and we're looking forward to learning from you and hearing your perspective and your lived experiences. So our patient guest speakers, we have Morgan Kelly, who is one of our IIAN committee members. And then we also have Sarah Johnson here with us and Ashley Hope. And then Sarah, I know you are planning to introduce Dr. Boris, so I'll let you do that.
All right. Yes, we have a very extra special guest speaker, Dr. Boris, who is actually my former doctor. He's a board certified pediatric cardiologist. He started his LLC in 2020 and has been treating POTS patients since 2002. Do you want to introduce yourself a little bit more and then we'll hop into our patients a little bit more?
Sure. Thank you, Sarah. So I am an older white male with brown hair and glasses and a blue plaid shirt. How's that? Um, so I have been practicing pediatric cardiology for 27 years. I've seen, but started taking care of POTS patients in 2002. I've seen probably over 1,200 POTS patients and created the POTS program at the Children's Hospital of Philadelphia, and probably one of the largest pediatric POTS databases in the world, and have published a fair bit of research in the field. Um, and so very happy to be here with y'all tonight.
And for our patient guest speakers, if you guys want to go around and just give like a brief little introduction, we'll definitely in the questions go more in depth about everyone's perspective. But if you just want to introduce yourself, that'll be great.
I can go. My name's Ashley. I am an African American woman with black hair, a pink shirt, and glasses. Yeah, that's my little intro.
My name is Morgan. I'm a white woman with brown hair and a ponytail, and I'm wearing a black shirt.
And my name is Sarah Johnson, and since there's two Sarahs, and I am a Native American woman with pigtail braids and glasses and a fall sweater.
Awesome. Well, thank you so much for introducing yourselves, and we really appreciate your time here tonight. To get started, what is your experience with dysautonomia? If you're comfortable sharing, what's your exact diagnosis, and give us a brief overview of what your experience has been like with dysautonomia. So you could talk about when did you start experiencing symptoms, a brief description of the dysautonomia that affects you, anything like that.
I would love to share. I was a teacher, a preschool teacher, and I actually got COVID in the very beginning of 2020 and developed symptoms shortly after that. And it took actually me leaving my job and like a lot of tumultuous things for me to get a diagnosis, but I did eventually get to see a specialist at Stanford, and I got my official diagnosis and then was put on medication. I had a bunch of really awful side effects to a lot of medications, and just a lot of complications with like treating my condition, mostly because of the area I'm in is kind of a medical desert, if you will. I don't have the best, I'm really far away from the Bay Area. So, and I couldn't continue to go there. And so that was really, really difficult in my journey. I kind of had to figure out like what medication I needed and things like that on my own, and then go to the physician and say, I need this medication because I have this condition. So I had to really advocate for myself a lot, but I'm in a place now where I feel like my care team is finally kind of coming together, and I have treatment and have treated other conditions that we subsequently found. And so my POTS is a lot more better managed, which is such a blessing. For years, I could not move or get out of bed or walk really at all. It was pretty severe, my orthostatic intolerance. And so I'm just really grateful to not be in that place and actually have a better tolerance now. And it's interesting because it's such a tailored, thing. And it's so different for everyone.
For sure.
Yeah, no,
I'm glad you have that kind of team coming together. Sorry, Morgan.
Right, no, you're good. I was gonna say I definitely agree a lot with what you said, Sarah. Like I had a lot of the similar things happen in my case as well. I didn't have COVID, but mono is kind of what kicked off a lot of my symptoms. So back in 2019, I had gotten mono, and basically ever after that, I just didn't get better. I had gone to my PCP. I was feeling awful and not being able to do things as I was able to before. So I was a cross country runner, for example, and I just couldn't run the same way I could. I couldn't walk the same way I could. I was having these issues, and they kept running CBCs and saying like, oh, you're fine. There's nothing wrong with you. It wasn't until 2021 when I started passing out that I finally got into the treatment that I needed and to see the specialist that I needed to see to get diagnosed. When I was first diagnosed, I was passing out excessively. It was really scary. I didn't know what was happening. And again, I didn't have answers for a very long time. There was definitely like a year or two where I was incapable of doing a lot of things. So I have POTS and vasovagal syncope. Those are my two main diagnoses. And the POTS would trigger the vasovagal syncope. And when I would pass out, it'd be very hard, very fast. And it was hard sometimes to tell when it was coming on. And so I lost my ability to drive. I lost my ability to again walk, do any sports. And as a high school student at the time, that was really awful. Because that's what my whole social life was. Granted, a lot of that was shut down due to COVID. But thankfully now I'm doing a lot better. I figured out a lot of treatments, and I also have a lot of comorbidities. I know you mentioned you have gastroparesis. I have that as well. That definitely made a huge difference in getting that treated. So now I'm in a much better place, but it's definitely a long journey, and thankful to be where I am. So.
Oh, I can relate a lot to what you both said, especially Sarah with being a preschool teacher. I was a pre-K 2 teacher before I developed my POTS and my IST. I remember, I was good, and then all of a sudden, January 1st, 2023, I woke up and I just hadn't been the same ever since. That was my first ER visit. We couldn't figure out why I had chest pain, why I was so dizzy. Just a lot of symptoms that we didn't have answers for. And then I saw my PCP. They said it was just anxiety at first, which was really disheartening because I was going through it, and to hear that they thought it was just anxiety was really upsetting to me. But long story short, 3 months later and 2 doctors later, I was diagnosed with POTS and IST, which I'm so grateful for because I know a lot of other people have had to go longer periods of time before they got diagnosed. But yeah, things were just kind of bad. So yeah, I got diagnosed within 3 months of having my main symptoms, which I was saying I was really grateful for because I know a lot of people had to go much longer before they were able to get diagnosed with their things. But yeah, starting out, it was really, really rough. I think I was talking about how I was passing out multiple times a day, every day, for the first 6 months of being diagnosed. And then slowly as I've learned different things, and medication treatment, as well as getting my infusions every week, I've been doing a lot better. So yeah.
Great, thanks for sharing.
Yeah.
Morgan, do you want to jump back into what you were talking about?
Yes, I'm sorry. I was saying how just repeating the fact that I had gotten my mono in 2019 and I wasn't diagnosed until 2021. So that process getting diagnosed initially was technically long, but it was short in another way. When I first started passing out, again, when it really got bad, the daily passing out, I had quite a quick turnaround, thankfully, in my diagnosis process. It was probably maybe 2 months. And so I had to see one cardiologist to get into the specialist. So they had to do a pre-screening first. That provider diagnosed me with orthostatic hypotension and then referred me to the specialist who then diagnosed me with POTS and vasovagal syncope. So I guess the orthostatic hypotension, as we kind of talked about earlier, might not be valid, but that's kind of how I got diagnosed. And we did two tilt table tests. That's because the first time they were kind of confused because there seemed to be a lot going on with both my blood pressure and heart rate. So they decided to do it again so that they could get a better analysis and comparison between the two. So yes, that was my diagnosis process.
Thank you for sharing that, Morgan. And Ashley, just so you know the question, we were talking about what is it like or was it like to get diagnosed? So how long did it take for you to seek help and how many doctors did it take to get diagnosed? So more specifically, what that process looked like for you.
Okay. Oh, do I wanna? I can go.
Oh, yeah, Sarah or Ashley. Sorry, I didn't mean to put you on the spot.
Yeah, just saying I got my diagnosis in 3 months was pretty good. But I was really overwhelmed at first. Like I said, I was told that a lot of it was probably anxiety related and mental health related. And so I was really discouraged, not really knowing what was going on. But for the most part, I had really good doctors, kind of what they were saying, where my first doctor kind of did a pre-screening and they said that I had IST, but also it sounded like I might have POTS. And that's when they sent me to the POT specialist in their office. And then that's when I had my tilt table test. And then I was diagnosed with POTS as well. So it was a pretty like seamless process, I would say. So I am very grateful for that.
Thank you.
Before we hop into Sarah's answer for that, could you briefly explain what IST is, Ashley?
Oh yeah, sorry. It's inappropriate sinus tachycardia. And so from my understanding, it's where your heart rate is above 100 beats per minute at rest. And so mine you 15, 120 just sitting or laying down. And I think also if you have like a 2-week Holter monitor, as long as your heart rate is above, I believe 90, if that's your average for the entire Holter monitor, then you're also diagnosed with IST as well.
So you don't have to actually, you can do the 24-hour Holter monitor. The average heart rate has to be over 95 or greater, 95 or greater. And you're right, a resting heart rate of 100, a single resting heart rate of 100. And it is absolutely possible to have both inappropriate sinus tachycardia and POTS at the same time. You can have both.
Well, thank you, Dr. Boris, for clarifying. And Sarah, thank you for being patient for that. You can jump in with your answer if you'd like.
Oh, I feel like my process was a little difficult. So to give some background, I live in California and I live in the San Joaquin Valley. So it is a pretty impoverished area and the services are not the best. And I have state health care, so that really prolonged the process for me of getting diagnosed and getting proper treatment. It was honestly really, really traumatic. I spent probably every month, like I was in the ER multiple times, for about 2 years. So it was just really scary. And it took, like, I went to a cardiologist, then to an electrophysiologist, then to another cardiologist, then to another electrophysiologist, then to the POT specialist at Stanford. And I just kept going to like all of these different people. And then I actually ended up having, after I was diagnosed in 2021, like years later, I saw an electrophysiologist and I also had an ablation, which ended up really improving a lot of my POT symptoms. And so I basically was having like these huge, like ups and downs throughout the day, where on top of my POT symptoms, my heart rate was going to going high, but then it was dropping to like 30s and 40s. And it was doing that like numerous times throughout the day. And so it was just really exhausting, and provided a lot of symptoms because when you have POTS as well, they just kind of played with each other. And so when I got the ablation and got the correct medication for that issue, it simultaneously helped my POT symptoms so much, actually a dramatic amount. I'm on a lot of different medications now, and learned that I have hyperPOTS, which I had to kind of figure out on my own because I first got put on other medications for people who have like a lower blood pressure, and I have a higher blood pressure upon standing. And so I was initially put on like a bunch of different medications that made me really sick. And then now I'm taking Corlinor, a beta blocker, and then my arrhythmia medication, and for like my POTS and stuff. And I'm doing end of infusions. I do infusions weekly. And that's been so helpful, like night and day difference. I've been out of the ER for probably like 6 months or so, which is fantastic.
Great. I'm glad you're finally finding some things that help you. So you guys kind of touched on this a little bit already, but what is your day-to-day life like now, and what has your condition or conditions changed for you? So like what symptoms do you experience on the daily? How's your life different now versus before when you had a diagnosis? And what challenges do you kind of face on the day-to-day?
I can share. So when I was first diagnosed, I spent a lot of time in bed. I would say I was probably bedbound for 6 months last year when I first got diagnosed. And then the second 6 months was a lot better. But like I said, I was passing out multiple times a day, every day. Very, very little energy. Walking was a huge struggle for me. I wasn't able to walk or stand for very long periods of time without passing out or feeling like I was going to pass out. But now I would say like there has been a lot of improvement. I think the last time I passed out was probably like a week and a half ago, and I would say it's probably maybe I go like 2 weeks without passing out now, which is huge. And I think that's definitely attributed to my infusions that I get, because I definitely noticed that without those infusions, I get super dizzy and my lightheadedness is worse. And that's when I'm more prone to have pre-syncope and syncope. But I do still get really, really tired just because I do have the IST. My heart rate is always above 100. And so I do get pretty tired. So I usually only have, I like to call it like usable energy. So I usually only have 3 or 4 hours of like usable energy in the mornings. And then I spend pretty much the rest of the day, afternoon, in bed or just resting around the house. Um, but honestly, that's a lot better than it was when I was first diagnosed. So I'm doing a lot better because of the medication I'm on and because of the infusions that I get.
Nice. Thank you for sharing.
Mhm.
Yeah, so my life, I feel like there's been like two phases of my pot, similar as Ashley explained, in the sense when I was again first diagnosed and very severe compared to how I am now. I still definitely have pot symptoms, but I don't in any way pass out the way that I was. And so when I was first diagnosed, though, it was entirely debilitating to my life. I lost the ability to have any independence to do anything that I loved or enjoyed at the time because, again, I used to be so physically active. So losing that outlet as a student athlete was huge for me. And then also not being able to drive and go to places, especially during COVID when it's already so isolating, just to kind of be bed to your like bound to your bed and not be able to get up and even see like the family that you live with in the capacity that you want to. So that was really frustrating. I'd say now though, the biggest changes in my life, like I have gained a lot back, thankfully, but I still definitely have to be very, very conscientious of how I'm spending my energy and how I'm planning out my days. I can't just do things on a whim to the degree that my friends might be able to. And then also like the medications and stuff that I have to take. I definitely notice if I miss a dose or so, or like I take a lot of salt tablets. So even just missing one of those or not taking the dose that I need to, I can feel it very strongly. And so just being super aware of kind of how my body responds and reacts to things, I'd say is probably like the biggest change I've experienced.
So for me, I feel like my life is very drastically different. At which for everyone it's very drastically different. But I had just started teaching and like started getting my life together when I got sick. And so it was really devastating because I had just gained my independence. I kind of started later in life because I had a traumatic childhood. And so I had just started working, got my license, like all of these things, and was independent. And then to lose all of that, and still now with my health the way it is, I don't have a lot of those things still. Like you're talking about driving and being able to like do things independently, cooking, things like that. It's super difficult. And it's a huge adjustment. I'm really, really, really grateful. I have my mom is like my caregiver, and she's like the most amazing person in the whole world. And she really helps so much. Just I wouldn't be able to. I mean, I would do it. Obviously, you have to get through life, but you know what I mean? She just helps so much. And she's such a blessing. Uh, but things are just so different. And I think I've learned to like lean into the slow, um, basically. And that's kind of how my life is different now. Um, is that my life was very chaotic before and very fast paced, and now it's very slow, and I have to go with the flow. I don't really have a choice. I have to be very fluid, and it's become kind of a blessing. I really enjoy my quiet time and my time to myself now. And I used to really struggle with those things. So I think that's like a part of how my life is different that I enjoy, um, because it really does make you kind of slow down and appreciate the smaller things.
Thank you so much for sharing. Our next question is, what treatments have you tried? What's worked and what hasn't worked? So I know you all touched on this a little bit, but if anyone wants to chime in.
So I have tried quite a bit of different medications. I took a bunch of different things in the beginning, like a bunch of different medications, and had a lot of adverse reactions to different things. And then I started doing my own research and learned about the difference between the different subtypes of POTS and like what hyperPOTS is and the different medications for the different subtypes of POTS. And and then I brought Corlinor up to my physician, and he was very reluctant about it. But it actually ended up being like a huge game changer for me personally and my journey. Like it truly was like one of my miracle medications, if you will. And really changed me from like non-functioning to like semi-functioning. I also get infusions weekly because I do have gastroparesis as well. So I eat a mostly liquid diet and deal with not being able to consume enough water. And so that exacerbates my POT symptoms. So the infusions really help with that. And I take a beta blocker as well. But right now I'm lowering the dose because I have some bradycardia going on after my ablation. But yeah, I think what's so interesting about the medication when it comes to POTS is that what I've learned is every single person is like so vastly different. Like, what works for one person may not work for another, and a lot of people have to like combine different things. And I just find it really fascinating, honestly.
For medications, I've tried pretty much everything under the sun that exists. So I was first prescribed beta blockers, which immediately failed because I have low blood pressure to start with. And so it just very, very much dropped my blood pressure even more. So we actually tried three of them, and none of them worked, obviously. And so then we moved on to midodrine, which I had some success with for some time, which was great. Unfortunately, the dose I needed to have a significant change or improvement would cause the tingling side effects. If anyone's taken midodrine before, oh my gosh, it felt like I was on fire all the time. So I stopped taking that. And then we looked at just really increasing a lot of my salt intake. And so I take an excessive amount of salt tablets, drink tons of liquid IV and tons of water. And so that has really helped a lot. The issue is my gastroparesis got really bad, which made things a lot worse with my POTS. So as my gastroparesis got treated, thankfully my POTS got better as I was able to consume more liquids. I've also tried compression. I haven't noticed a significant difference. I still wear it, but it hasn't made much of a difference in my life. The biggest thing I'd say outside of like the water and salt is making like small adaptations to my lifestyle and trying to be as active as I can be, even in the small ways. And I know a lot of doctors like to push exercise with POTS patients, and I think that there's definitely helpful, but I think that there needs to be an understanding that it's like a spectrum in a way. Like exercise and physical activity, like yes, they're important, but it's like a continuum. Being physically active with POTS can even just be like, hey, I'm going to sit up 5 minutes more than I normally would, as opposed to laying in bed, because that is enough of a workout if you're at 120 sitting there, you know? So for me, trying to slowly adjust and increase and push my body a little bit in different ways, but not overdoing it, I have found has gotten me quite far. Surprisingly, I didn't think it would, but yeah, I know that's not like a tangible treatment, but that's one of the things I found to be really helpful.
So what treatment are you on for your gastroparesis?
So my gastroparesis, we also tried a lot of medications. Right now, I actually don't know the name of it, but I'm on a medication that's used to treat myasthenia gravis, actually. And I also have
You're on
intestinal.
my favorite medication. It's Mestinon or
Yes,
pyridine.
it's amazing. I've had gastroparesis for like 3 years. I have tried everything under the sun. It was surprising that I just now found this medication like 3 months ago. And I have intestinal dysmotility. So as they treated that, my gastroparesis has gotten so much better. And then again, my ability to consume water has gotten better, which is huge for POTS.
I can relate a lot to that too. For me, I would say the infusions are number one. Like I said before, without those, I get super dizzy, super lightheaded, and have the pre-syncope and sometimes syncope. I have tried a couple different beta blockers, and I am on one, and I think that it works pretty well for me. It's interesting because I tried it first when I was first diagnosed, and it didn't help very much. And then I switched to a different one, and then switched back, and it seems to be working better for me now. So that along with the infusions, but I also try to drink a little bit more water. I have cyclic vomiting syndrome and functional vomiting. So it's really hard for me to stay hydrated sometimes during episodes. And so that's another reason why I have the infusions. But yeah, staying hydrated. I have a liquid IV, try to do like the drink packets. And then also the compression, kind of like Morgan was talking about. I haven't really noticed like much of a difference with the compression. But I also need to like do it more often. I feel like I haven't really given it like a fair chance. So that's definitely something I want to like look more into, but definitely the infusion and the medication for me.
Nice. Thank you guys for sharing. So our second to last question here, what has been your experience in the context of institutional structures in terms of support or lack thereof? So things you could talk about are like, what difficulties have you had navigating the healthcare system? Have you experienced stigma or discrimination? What changes do you want to see in these institution structures? That kind of a thing.
I've had a really hard time personally in this like particular category. I've been fired from probably like 10 doctors that basically just said, I like you're too complicated, I can't help you, sorry. After I was like established with them essentially. And I had that happen just numerous times with numerous specialists. And it was really disheartening and difficult. And I think the thing is that when you're in that place, like where your symptoms are so uncontrolled, emotionally, it is very hard. Like you're barely hanging on each day because your symptoms are so strong and your life is so chaotic and you have no idea what's going on. Like it's very scary. And I think that that's one of the things that I ran into the most that I had problems with was like the lack of empathy from physicians when it came to the emotional toll. Because I would cry or I would get upset and then I would be labeled like psychotic essentially, and psych would get sent to me, and they would go that whole avenue just because I was upset that I wasn't getting treatment for a physical ailment that was like frustrating me. And I think that's for me an aspect that's been really difficult, and it's really hard to actually have resolve, because I think it would be really wonderful if us as disabled people have had the opportunity to speak to those physicians in a setting where you can talk to them with a supervisor, with somebody else, and actually talk through what happened. But I think the way that the system works now with grievances and just how the process is, it's very like he said this, she said that. And I just think it doesn't solve a lot. And I feel like communication, if there was just more communication between the complex patients and the physician themselves, that so many things could be improved upon for sure. It's been a very difficult journey for me, but I'm grateful that I've made a lot of friends, and I've actually been able to help them in the beginning of their journey and them navigating going to the ER and talking to these physicians and advocating. And so it's been a blessing because I've been able to use my experiences to help other people. And so I think there's a reason it happened, but the system is definitely a little broken in my mind.
No, definitely. I agree 110%. I think there's a lot of misconceptions that some providers tend to come in when treating patients who present with POTS, that certainly is systematic. I, for example, like have seen like I was told when I was diagnosed, I was in high school. So to most of the doctors I saw, I was just a young girl who wanted attention and wasn't getting it enough from whoever, right? And so that I feel like was a really huge barrier in getting access to care, was just these preconceptions that the providers came in before even getting to talk to you. They just saw your age on the chart or saw whatever it might be on the chart and immediately assumed that, oh, of course, this is just that, you know, she's heard about it from TikTok, I was told by a provider once. And I that's a crazy perception to have, especially when, you know, there's a lot of miseducation about POTS too and what it is, about the fact like, oh, you're going to grow out of it's like, you're going to grow out of it is a huge one. That's not the case with most patients. And it can be, which is wonderful for those who it is. But I think providers having a proper understanding of what the condition is, what it presents as, and that it's a real condition at the end of the day is huge in treating these patients and making sure that they get heard and the treatment that they need. So
Yes, totally agree. Like, I think like what you guys both talked about, and how I mentioned before, my doctor saying it was just anxiety. I have like a diagnosis of bipolar, and so she also kind of wanted to pin it on bipolar too, instead of actually like listening to what I was saying, because we don't go to the doctor because we want to. We go to the doctor because we need help, you know? And like I was saying earlier, it was just really discouraging to hear somebody that I trusted for a long period of time kind of just like brush off my symptoms and tell me that it was related to my mental illness. I think, and I don't really know why a lot of doctors default to it's a mental health thing before they default to, okay, there's actually something going on. But I think it's definitely something that needs to be talked about more, just so that the assumption isn't made immediately based off of like a previous diagnosis or something like that.
and not to interject with that, but I think part of that is the reason why maybe the three of us share this on the panel is because we're women. And I have a friend who is male who has POTS. And it took him a month to get diagnosed. And the contrast between that, well, granted, yes, Ashley, you said you had a very quick turnaround, but he wasn't passing out or anything. And I think a lot of times that male providers tend to assume that female patients are just having hysteria, or it might be some sort of other emotion that's going
What
on.
is so interesting about that is my dad actually went to the ER, the same exact ER that I went to like tens of hundreds of times, and he was admitted for 5 days. And he didn't have a heart attack. He didn't have it. Like his symptoms were less severe than what I was dealing with. And I never once got admitted.
That's crazy. No, my
They
grandpa
they
has
just told me it's anxiety. Like you're fine,
yeah,
you know.
my grandpa has dysautonomia as well, and it took him like that to get diagnosed. So there's that, and then my friend as well. So I think it's interesting. Not that that's the question, but I just wanted to point out, I think that's another systematic issue we have here. It's just the perception of female patients being hysteric, and that's why their diagnosis is automatically written off as it being some sort of other cause.
Yeah, thank you for saying that. Because, like, I don't know. I feel like when it comes from somebody else, it makes a lot more sense. But I feel like that was not something that I was thinking of. And that completely makes sense. So, yeah, thank you for sharing that.
And I don't remember the exact number, but I know in our presentation as well from the earlier of the month, it is like significantly, if you average at least the people surveyed, and like I believe it was a big pot survey, I could be wrong on that. It did take male patients a significantly less amount of time to get diagnosed with dysautonomia as female patients did. So it's something, you know, to consider. It kind of spreads beyond dysautonomia and other things too, but good thing to bring up and be aware of, I guess.
Thank you for sharing the stories, and I'm so sorry that you face so many difficulties and challenges, and these are definitely things that we need to be talking about. So really appreciate you guys bringing this up. Before we transition to asking some questions of Dr. Boris, we have one final question for our patients, and that is, what advice would you give to someone who is newly diagnosed or suspected of having dysautonomia?
And try to keep it a little brief to, like, you know, a couple sentences or two.
I will say this completely super short because I've actually thought about this a lot. And my sentence is, trust your gut. You know your body. Doctors have been wrong so many times, but I have never been wrong so far. And I think that, you know, when you know, and I think we all know what that feeling is like, and that, in the beginning, doctors kind of try to convince you that nothing's wrong and you're fine, but our guts really know what's really going on. And I think that when we lead with that and we fight with that, that's when we, find the answers that we're looking for. And I think just don't give up, don't give up the fight, because you will get there.
I think one thing for me, what I've seen with a lot of people who are newly diagnosed or suspecting POTS is that they wait to start treatment until their the doctor tells them they can. And I think there's a lot of lifestyle changes you can make with POTS now. You don't necessarily need that label to come. So, drink more water, wear compression, take salt tablets, whatever it might need. You know your body best. Make those changes now. That way you can go to the doctor and they can better support you in getting better and, obviously improving your POTS.
Do agree with you, Morgan, in that aspect. I would just also caution people for not taking salt tablets necessarily, because you don't necessarily know what kind of POTS you may have, and if you're dealing with blood pressure issues as well. Like, wait for a doctor until you start drastically increasing your salt, but definitely, electrolytes are nice. You can have some Gatorade, increase your fluid intake, but be careful about.
I didn't think of that. I was coming from my hypotension perspective, and I was like, salt tablets are great.
No, yeah,
take salt tablets if you have hypertension. Okay, sorry.
I would say educate and then advocate. So be educated on what you think you're going through so that you can relay that to your medical professional, and advocate for yourself. That is something my dad is driving into my head, because growing up I never advocate for myself. But definitely having that as something that you take to a doctor's appointment with you, advocating for how you're feeling, how your body's feeling, what you're going through. I think that's really important too. And then, of course, educating yourself on what you may think is going on, because Sarah said, your body, and you're usually right about what's going on in your body. So, yeah.
Awesome. Go ahead, Bernard. Sorry.
I was just going to say that's great advice. Thank you so much. And we want to say thank you once again for sharing your stories, your perspectives. We know it's not necessarily easy, so we really appreciate your time and your vulnerability. And I guess now is a great time to transition to questions for Dr. Boris, if we're ready.
So before we do questions, there's a lot to address here that's already been discussed, and I want to kind of jump into some of that. First off, the diagnosis of POTS is a combination of at least 3 months of symptoms of chronic orthostatic intolerance, so lightheadedness, tachycardia, fatigue, brain fog, nausea, headache, those kind of things, as well as a sustained increase in heart rate in the first 10 minutes of upright position of at least 30 beats per minute for adults. Officially, it's 40 beats per minute for adolescents, although we published a paper a few years ago that showed that the symptomatology in patients who had a 30 to 39 beat increase versus a 40 or more increase was not any different. So I actually use 30 for my adolescents as well. So it's not simple orthostatic measurements, lie down, sit, stand. It's a 10-minute either standing test or a tilt table test for that diagnosis. So that's number one. Number two, it absolutely affects females more than males. Anywhere from 3.5 to 1 to 5 to 1 female to male ratio. We just published a paper this past summer that's available for anybody to read in the Journal of the American Heart Association of our first of 3 long-term outcomes survey papers. We found that female patients had more symptoms, more severity of symptoms for longer time than male patients, okay? What we also found is that 99.1% of patients were still symptomatic, and the average duration of symptoms in our survey was 9.5 years from onset to the time they took the survey, okay? The average age of the patients was almost 22 years. And yes, female patients for decades and decades and decades in the medical establishment are marginalized and gaslit. Before they had CT scanning, patients who had multiple sclerosis were told that they had hysteria, and it's really unfortunate. It's very easy to throw a psychiatric disorder with psychiatric diagnosis at patients because because a lot of times doctors feel like they know everything they need to know about the topic, and they don't need to learn anymore. They don't need to research anymore. They don't need to say, I don't know, but I'll get you to someone who does, or I don't know, but let me do some more reading and get some more information for you. In the Big Pot survey, which was someone referenced, I think Stephanie referenced earlier this evening, at least 50% of patients took at least 7 doctors before they got a diagnosis, and 23% of patients saw at least 10 doctors before they got a diagnosis. It's gross. It's disgusting. As far as therapeutic interventions, my approach, which I think and my patients think make a lot of sense, is I like to address the 3 or fewer worst symptoms that are interfering the most with patients' activities of daily living. And as has been brought up before, everyone's different, right? So your top 3 might be different from someone else's top 3, okay? I do use both non-pharmacologic and pharmacologic interventions. I feel that the non-pharmacologic interventions are foundational, meaning that's what you need to build on. And yes, it's not just increased fluid, increased salt. It's 80 to 120 ounces of fluid a day and 8 to 10 grams of salt a day. Not a fan of salt tablets. Salt tablets tend to upset patients' stomachs, but there are salt supplements that come in capsule form that are much better tolerated by patients. The concept of compression is also good, but it's not just compression in general. There was a really good research paper that came a few years ago out of Canada that showed the use of an abdominal binder works better than compression stockings. Okay. Although for some patients, they can't, because of abdominal pain or GI issues, they can't tolerate an abdominal binder. And so compression stockings, not compression socks, not knee high, we're talking waist to toe, 20 to 30 millimeters of mercury compression, worn while awake, so not 24/7, can be really helpful. Elevating the head of the bed on a cinder block or risers for patients whose symptoms are worse in the morning can help really start their, Sarah likes that one, can really help to reduce their morning severity. Also, when you wake up, just chug 16 ounces of cold water straight away, and that actually causes a couple of different changes in your body that can help to support your blood pressure. For those patients who have heat intolerance, the use of a cooling vest can be amazingly helpful in just allowing you to be more functional out in the heat, out in the world. And exercise was talked about before. Specifically, there's a protocol that I utilize that I actually helped to write that you can find online, for at least it's for adolescents, called that I refer to as the Dallas Protocol. It's hosted by Dysautonomia International. If you can do an internet search for Dallas Chop Pots, it's an 8-month protocol, does leg and core strengthening and cardio. And it starts out with recumbent, not upright exercise initially, and then as well as leg and core strengthening. What my patients tell me is when they get to month 4, 5, 6 of this protocol, they really feel like their symptoms are much better reduced, assuming and controlled, assuming everything else has been diagnosed. One of the things that hasn't been discussed here this evening so far is the concept of mast cell activation syndrome, right? And so in our long-term outcomes survey that I referred to before, 21.5% of patients had felt or stated that they were diagnosed with mast cell activation syndrome. In my present practice, I've seen over 200 patients so far in the 4 years that my practice has been open. And I would say probably on the order of 70% of patients probably have mast cell activation syndrome. And if that's not adequately being addressed, you're not going to get your POTS symptoms under control as
I
well.
have can I ask you a quick question? Do you have any advice on how to go about getting an MCA's diagnosis
That's a tough one, right?
when and the allergists in your area like just want to do a simple tryptase and that's it?
Correct. So, so let's talk about what mast cell activation syndrome is. The mast cells are part of our immune system. They're the guards, they're the sentries. They're looking for foreign proteins. And when they encounter these foreign proteins, they release a whole host of inflammatory chemicals or inflammatory mediators that call in the immune system. What's thought to be happening in the setting of MCAS is the threshold for releasing these inflammatory mediators is lowered. So certain foods, certain inactive ingredients and medications, having your period, certain weather changes, stressors, certain smells or fumes or smoke can all set it off. The diagnostic criteria are argued about. There's a very conservative view that says it's just an increase in your tryptase level, and tryptase is an inflammatory mediator. But there's others that say, well, no, an increase in methylhistamine or prostaglandin or leukotrienes or some of the other inflammatory mediators are good, are also elevated. And so, truth be told, the problem is that these inflammatory mediators have a half-life of 1 minute. And so a lot of labs are not set up to do this. So I don't even do the lab testing. I just see how the patient responds to entry-level therapy. And entry-level therapy is histamine receptor blockade, H1 and H2 receptor blockers. So I'll start patients off with twice a day Zyrtec and twice a day Pepcid and go from there and see how they do. But I think a lot, in 9 years ago, in 2015, I'd never even heard of MCAS, and had a patient whom I tried everything and nothing was going right and nothing was getting better. And she went and saw an allergist immunologist who diagnosed her with MCAS. And I'm like, what is this MCAS thing? But she came back to me much better. And so as time has gone on, it's more recognition, it's more absolute, it's more understanding, and it's also the more you ask, the more you find. So if you don't ask, you're not going to see it. Right. And I think a lot of doctors just don't get there from here. And a lot of doctors also don't want to acknowledge that this is a problem. So anyway, so that's sort of an intro. I mean, we can start with other questions as well.
No, that was a really helpful introduction, and thank you for sharing some of those really important resources. But I guess we'll kind of start off with our question list in terms of how and why did you get into pediatric cardiology, dysautonomia? What did that journey look like for you?
So pediatric cardiology and POTS are very different. Pediatric cardiology sort of snuck up on me. I was a third-year medical student, and I diagnosed, just by doing a physical examination, I diagnosed a patient with a congenital cardiac defect that the pediatric cardiology fellow and pediatric cardiology attending missed. And I was like, that's cool. So I really love the physical examination and just using your ears and using your knowledge and using the understanding of cardiac physiology to be able to make a diagnosis, or at least a list of potential diagnoses. POTS is a different issue. My first patient in 2002, well, actually prior to that, I'd been taking care of a lot of patients who had syncope and lightheadedness and was pretty successful doing that and really enjoyed that. And had a patient who was just not getting there from here. Everything I did, I couldn't fix her. And I'd heard of this POTS thing. I thought, well, maybe it's this POTS thing. And I did some reading in the medical literature, and this name kept popping up of an adult cardiologist in Toledo, Ohio. And I cold called him. Hi, you don't know me, and we talked for 2.5 hours, and he taught me a lot of stuff. And so as time went on, just kind of kept seeing patients and And then in 2007, came to the Children's Hospital of Philadelphia. People found out that I could take care of these patients. And then the heavens opened up and I started seeing a lot of patients from literally all over the country. So created the database, started doing research and publication on this. This is what we're seeing. This is our experience.
Awesome. Thank you for sharing that. Do you have any general things that you would recommend dysautonomia patients to do versus not to do when trying to find their diagnosis or if they think they have it?
Yeah. So I'm very on the fence about Dr. Google. I think that a lot of people come in with preconceived notions of what their diagnosis is. And yet, by the same token, I think there's also a lot of people who don't know, and the physicians don't know, and they just get blown off, and so it's hard. Sometimes you sort of have to do a little bit of reading and talking to folks and trying to find out what all's going on. I agree with what the folks said before, Sarah and Morgan and Ashley. A lot of self-advocacy, unfortunately, self-advocacy needs to occur. And if you feel like you're not getting the appropriate care, or you feel like you're being marginalized or gaslit, kick that doctor to the curb and find someone else. I mean, and yes, it's going to look like you're doctor shopping, but if you're not getting the care that you need to reduce the symptomatology and to manage the symptomatology that you have. So we have 2 other papers we're going to publish in long-term outcomes. And can I tell you, despite the fact that these patients have a chronic illness, 97% of patients by age 21 either had a high school graduation, a high school diploma, or a GED. That's insane. That's crazy, amazingly awesome, right? I mean, how many chronic illnesses do we see in adolescents that patients can't get through high school, right? These patients are amazingly driven. 80% of patients go to college. It's awesome, right? And the ability to do so is so important. And so you need to be able to achieve. And the good news is that I think with appropriate therapy, the large majority of patients are actually able to achieve and are able to be functional. I've had patients get back to playing volleyball, swimming, running track, playing field hockey. It is absolutely doable.
Thank you so much. What would you say is the most challenging part about treating patients with dysautonomia for you as a physician?
So let me back up. I think we need to be very careful with the term dysautonomia, right? Dysautonomia, as was mentioned before, is an umbrella term. So I treat patients with syncope. I do treat patients with IST. I treat patients with POTS. Dysautonomia also includes pure autonomic failure, multiple system atrophy, Parkinson's disease, Lewy body dementia. What am I missing? Diabetic autonomic neuropathy. So and the reason I'm being such a snotwad about this is because I actually was the lead author on a data dictionary. I'm kind of a data nerd too, and so we really want to make sure that we are using very specific terms and definitions. So I think one of the hardest things for me is, and I say this to patients, I wish I had a magic wand that I could just sort of say, the therapies that you need are ding, these 3, right? And it just doesn't work out that way. And what ends up happening is sometimes, to mix my metaphors, sometimes I get a home run, sometimes I get a base hit, and sometimes I strike out. And so that doesn't, the good news there though, is I have lots of, see, right? Exactly. So the good news is I have a lot of options. I have a lot of different therapies that I can use. And so, hope is not lost in case therapy number 1 is a complete fail. There's a lot of different things that we can do to help make these patients better. But it is disappointing when I have patients, and I guess the other part B of that is when I've been seeing a patient for multiple times and I'm still not getting past, I'm still not able to help them. And the question comes up, what else am I missing? What am I not getting? And sometimes that's hard.
For sure. Thank you for sharing that. What do you think is a very impactful, I hate saying the most impactful memory you have regarding dysautonomia or the different conditions that you are familiar with treating, but what's one that jumps to the forefront of your mind?
One thing I think that's really cool for me, having done this for so long, is now I've seen some of my former patients go to medical school, go to nursing school, go to physical therapy school. I've actually worked with a couple of former patients who are now nurses. That's great. That's so sweet. And certainly their experience with a chronic illness, I think makes them a much better clinician as well from that standpoint.
That's really cool to see.
And then our final question is, what would you want patients and doctors and medical professionals and the general population to know about the conditions you treat? If you could really...
Well, let's start with the doctors. And what I would want doctors to know is they need to pull their heads out of their what and read and learn. And I get it. A lot of doctors are like, I didn't sign up for this. This is not what this, I didn't train for this. I didn't learn this. This is not what I signed up for, right? Cardiologists, pediatric cardiologists want to take care of kids with heart disease. POTS is not a cardiac disorder. Electrophysiologists who are cardiac specialists who specialize in the electrical system of the heart, that's what they want to do. They want to do the ablations like Sarah was talking about. They want to put in pacemakers, right? Managing POTS is not a cardiac disorder, but no one owns the autonomic nervous system. Neurologists don't either. Gastroenterologists don't either. Generalists don't either. And so I would say, open your mind, open your eyes, read, learn. These patients are out there. They need your help because there's far and away not enough providers out there taking care of these patients. For patients, that's a tougher one. I think what you need to understand is we doctor types, there is wide variability in the way patients are being treated. There's wide variability in the way patients get care, even from doctors who are quote POTS specialists, right? And so, what you'll see a cardiologist who's like, I only take care of the heart. I don't take care of the nervous system stuff. I don't take care of the GI stuff. What you'll also see is you'll see people who have a monolithic approach to how they manage these patients. So, the only tool in their toolbox is a hammer. Everything looks like a nail. And I think both of those approaches don't serve the patients well. I think looking for somebody as best as possible who is not only validating, right, to your medical condition, but is knowledgeable and creative. I think the creativity part of it is so important to sort of say, why don't we try this? Because I think this might be helpful. And make sure that they really address your symptoms and not just the general concept of POTS, because the general concept of POTS is different for everybody.
No, that's really helpful. The hammer and the nail metaphor really drove it home for me. I appreciate that. That was kind of our formal list of questions, but if you have anything else you want to add or share, we'd love that. But otherwise, we just really want to say thank you for your time. We really appreciate you being here.
So there are questions on the chat. Do we want to knock some of those out?
For sure. And I would like to say, if anyone does have a question for Dr. Boris, please try to make it a general question and not necessarily ultra specific about your specific experiences. We want to kind of keep it general, and we don't want to put Dr. Boris on the spot for any medical advice because that's not what we're really here for. But
That's all
try to
right.
keep it general if you can. But we really do thank Dr. Boris and all of our patient guest speakers tonight for sharing their experiences. And also feel free to raise your hand via Zoom too if you want to speak out loud versus typing your question in the chat. And do remember that you can type a question to Sarah in the chat if you want it to be anonymous.
So there's a question from Gary Woodson. Is POTS something that a lot of people who had COVID more than once? So let's talk about that. Prior to the pandemic, estimates of POTS in the United States was about 1 to 3 million, was thought to be about 1 to 3 million people. Post-COVID, the thought is it may be as much as 3 to 6 million people, right? So we know that a COVID infection or a SARS-CoV-2 infection with long COVID can cause one of several things: postural orthostatic tachycardia syndrome, mast cell activation syndrome, myalgic encephalomyelitis, chronic fatigue syndrome. And so POTS is definitely one of the things that you don't have to have long COVID more than once. You can have it just one. You can have a COVID infection just once, and it can throw you down the stairs, and cause POTS. Yeah, not seeing any other questions for me. If anyone else has any other questions, I'm happy to try to address them. Otherwise, while waiting, when I think of the symptomatology of POTS, I sort of break it down into kind of buckets. We have the orthostatic intolerance aspect of it. So we have the lightheadedness and the tachycardia, and the palpitations. We have the fatigue and the brain fog, right? We have insomnia as well, and sometimes those that can be related. We have the GI symptoms: nausea, throwing up, diarrhea, constipation, feeling full early, and abdominal pain. Excuse me. We also have muscle or joint pain. And then joint pain is not infrequently associated with joint hypermobility. As much as 61 or even 75% of POTS patients have joint hypermobility as well. So there's a lot of different buckets of symptoms that need to be addressed and recognized from that standpoint. So let's see, how do you help people around you understand how debilitating POTS is? Yeah. So I am not a patient. So that's a hard question because the symptoms are invisible, because it's so variable, hour to hour, day to day, because your friends sit there and say, "You were fine 5 minutes ago. What's wrong with you?" And it is hard. And you find out who your friends really are, because a lot of people are abandoned by their friends. People want to go out with, you want to go out with your buddies, your friends, and hang out with them. And they're just like, "Yeah, we're fine." Or they just stop talking to you. So it is difficult. I think, how do you open? That's a hard one. I'm not sure how to, I'll be honest with you. I don't know how to answer that. I think what you need to do is be honest. I think what you need to do is say your truth, and say, "This is what I got going on, and I do have a real diagnosis. Here's some resources. By the way, there's a paper that I published a couple of summers ago in 2022 in the American Academy of Pediatrics journal. It's called Pediatrics. It's also open access. It's called Pediatric Postural Orthostatic Tachycardia Syndrome: Where We Stand. and it is open access. So it talks about diagnosis and what the research at the time was, and so, you can give that to people as a reference. You can give them more simpler descriptions, like from the Dysautonomia International website. Full disclosure, I'm on the medical advisory board of Dysautonomia International. So not really, but not really, it's conflict of interest because I don't get paid. And so, show people as best as you can. Um, and I think those people who really in their hearts care about you and will take the time to do so will be interested. As a pediatrician, I see a lot of adolescent and young adult, and young adult patients. And it's a hard time. I mean, forget having a chronic illness. Friendships through high school, middle school, high school, and college change frequently. And people dump you all the time, and people find someone else, and it is what it is. And again, find the people who really have a good heart and really will be there for you. And of course, you do the best you can to be there for them. So there you have it.
Yeah.
Other
All you can do, like Dr. Boris said, is like speak your truth and, tell people how you're feeling and what you can and cannot do on any given day. And that's all you have control over. You can't control if they believe you. You can't control, how they're going to act around that. But like Dr. Boris said, like if they really care about you, if they value you, like they will find a way to accommodate you.
I agree. I agree with that. Other questions?
And just to read out what Sarah said, and new people will come into your life. It takes time, but I have made the best of friends in this chronic illness community. So have I.
Yeah, I mean, Sarah and I met at a Dysautonomia International conference like years ago, and look at us now. We started a nonprofit and we're raising awareness and impacting a lot of people, hopefully. So like you find a lot of commonalities with people who have other chronic illnesses too, and being there for each other, and you kind of understand what each other's going through in a way. Even if you don't have the same conditions, you kind of feel like the same kind of things.
And I think the thing to keep in mind is that this chronic illness or set of comorbid chronic illnesses does not define you, right? There are a lot of people on various social media who, to get eyeballs, don't treat their chronic illness and are just out there saying, this is what I got. And it's really, and I feel awful today and blah, 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 blah. And it's like, no, you're a person first. You have a chronic illness, but you have so much more inside you that you can do, and you have the potential to do. And don't let that be your number one descriptor.
I just wanted to add, speaking to what you just said, is that something that I didn't really talk about while we were speaking, but is a huge part of my life, is gardening. And it's something that became very difficult when I got POTS and was diagnosed and had orthostatic intolerance. I kind of learned to adapt and like container garden and like do tiny little things here and there. And it's grown a little bit as my symptoms have gotten better. But I just say that because pertaining to what you said is that there's parts of us that are still there, and that can still thrive, and we can still enjoy, things that bring us joy and things outside of our chronic illness. Sometimes it just takes looking at it from a different perspective and doing it in a new way, maybe.
I would agree with that, but I would also push back on that and say that I think there's more that can be done for symptom control. I really do. And that can really help a lot more patients that I think a lot of physicians are not familiar with. They're not familiar with necessarily all the medication approaches. They're not necessarily familiar with all the non-pharmacologic approaches. And they're not necessarily familiar with all the comorbidities also, craniocervical instability and median arcuate ligament syndrome. And, there's a new one, iliac vein compression. People are starting to look at that too. And I just think that, again, the concept of what are we missing in those patients who are having to limit themselves despite having seen a POTS specialist. My question is, what else is being missed? What's not being adequately treated?
Dr. Boris, just to follow up on that, I know that there are a couple of people here that are hoping to go into the healthcare field.
Yeah.
So I guess, and I know it's a really big question, but what would you say, like on the systematic level, what can rising students and what can we do like as learners of this system at the systematic level do to change that fact, to change
Yeah.
there's so much out there to be known that
Sure. So I think as learners, I think the first thing you need to do, the first thing you need to do when you're going, let's say when you're in medical school, is know yourself. Know what makes you happy. Know what things you enjoy at the end of the day. And so there's some people who would love doing surgery 5 days a week, right? There are others who, like me, love being in the outpatient clinic. And so I think it's and then do you like working with children and their parents? Do you like working with adults? I think you need to know yourself before we even think about stuff like issues of autonomic dysfunction and those kind of things. Be the best learner, typical medical school, for example, I can't speak for nursing school. My wife can, but I can't. Is first year you learn how the body works. Your second year you learn how the body fails, right? The diseases, and you learn how to do a physical examination. And then your third and fourth year are your clinical rotations. And so during those times, get the most out of that as you that you can. Is that sort of addressing kind of what you're asking? It's hard without getting more specific.
Yeah.
I think, from that standpoint.
That is very helpful. And I think that really that exploratory and taking the time to reflect on like what we enjoy is really important. So I agree.
What I had a physician tell me during, one of the attendings tell me during my third year of medical school is that think very hard about what you want to do, because in 10 years, the things that you love, you'll only like, and the things that you like, you'll hate. And I don't think it's quite that bad. But I think the other thing too, are these doctors that I'd like to hang out with? Are these the kind of people that I would, so case in point, I knew I did not want to be an obstetrician, right, or gynecologist. So I did my OBGYN rotation first in my third year of medical school. So if I screwed it up, who cares? I wasn't going to go down that pathway. And what I found was, at least, I'm older. I was I went to medical school in the late 80s, early 90s. There was a lot of misogyny. Even in OBGYN, I'm like, why the hell are you here? Why are you taking care of women if you don't like women? I'm like, what's up with you? And yet pediatricians were some of the nicest people that I ever, met and worked with. And I thought, wow, that's cool. And kids get better. And so that's cool too. And but that's me, right? That's what I looked for and what made me happy. So yeah, it's very person specific.
I appreciate that. Thank you.
I saw Win put a question in the
Before we get into that question, for those of people who might need to leave or wrap up, I was thinking we can do a little quick outro of stuff, and then we can go back to answering questions and whatnot for those of people who want to keep staying and keep asking questions. So obviously, please keep asking, putting questions into the chat, and we'll get to them. But we'll move on just to a little announcements. In November, like Dr. Boris was talking about mast cell activation syndrome and some mast cell diseases, we will be covering mast cell diseases next month in November. Our presentation meeting will be on November 6th, and our guest speaker meeting will be on November 20th. Same time, 8 o'clock Eastern, and same place, the Zoom link. So please mark those on your calendars if you're interested in coming to those. And again, for those of you who may want to watch this recording back later, you can go to the QR code and find our YouTube channel there, and our Instagram and everything like that, all on our link tree, and our newsletter. Sign up to get reminders and to also find out when this recording will be uploaded. We try to make accessible, we want to make all of our videos accessible, so the captions are not auto-generated and everything's all good and ready to go. So that's why it takes us a little bit of time to upload the videos. But as soon as we release that, we'll send out an email. So you'll be the first to know about it if you sign up for our newsletter, and just our website and other resources. So, and we can go back to questions now. But thank you so much for all of our guest speakers for being here. If you need to go, please go. But we'd love to have you and keep talking about all these things afterwards. So thank you so much for everyone coming to even see this presentation and hear these guest speakers out. We really appreciate your time, and we hope that you gained something out of it. So thank you, Dr. Boris, and thank you, guest speakers, for talking to us tonight.